Welcome to the Cognitive Autopsy, a premium companion series from the Chartered Defense. Each episode examines one missed or delayed diagnosis, not to assign blame, but to identify the exact moment where a different decision might have changed everything. I'm Bryan.
I'm Sarah.
And I'm Paul.
Tonight we're examining one of the most consequential diagnostic patterns in emergency medicine. A pattern that accounts for more serious misdiagnosis-related harm in American emergency departments than any other single condition. A woman in her early 40s develops sudden-onset neurological symptoms on a summer evening. Her mother calls 911 and tells the dispatcher she believes her daughter is having a stroke. EMS transports the patient to a designated primary stroke center, a hospital equipped and certified to diagnose and treat exactly this type of emergency. The patient arrives with slurred speech, right-sided weakness, dizziness, nausea, and vomiting. She is within the treatment window. The hospital has alteplase, TPA, available. It has teleneurology capability. It has CT imaging ready. The emergency physician examines the patient and arrives at a diagnosis: complex migraine. No stroke alert is initiated. No NIHSS score is documented. No neurology consult is placed. The teleneurology system, available and operational, is never activated. A non-contrast CT scan is obtained and is negative for hemorrhage, which is expected in early ischemic stroke and does not rule it out. By the time a neurologist is finally consulted, more than 5 hours have passed since symptom onset. The TPA window has closed. An MRI reveals an ischemic stroke. The patient is transferred to a tertiary care center for emergency surgery. She dies 4 days later.
The clinical sequence is worth breaking down carefully. A patient with focal neurological deficits presents to a primary stroke center. The stroke pathway is not activated. The question we're going to answer tonight is not whether the outcome was definitely preventable. There was likely an opportunity for earlier intervention. The question is, what was the cognitive process that produced this decision? What was the physician thinking? And what system allowed that thinking to go unchecked?
Before we trace the decision chain, we need to understand why this diagnostic error happens and why it happens repeatedly in hospitals across the country to physicians who are otherwise competent. Sarah, start us with the clinical overlap.
The fundamental challenge is biological. Stroke and migraine share overlapping symptom profiles. Both can produce focal neurological deficits: weakness, sensory loss, visual disturbance, speech difficulty. Migraine with aura is a subtype of migraine, a condition affecting approximately 12% of the general population, and it is characterized by transient, fully reversible neurological symptoms. A widely accepted mechanism is cortical spreading depression, a wave of neuronal depolarization followed by suppressed activity that moves across the cortex, temporarily reducing blood flow in a pattern that mimics ischemia. There's a clinical heuristic that clinicians often rely on. Migraine aura tends to produce positive symptoms, scintillations, tingling, visual phenomena that spread gradually over 5 to 20 minutes. Stroke, in contrast, tends to produce negative symptoms, weakness, numbness, vision loss, with sudden maximal onset. But this heuristic is imperfect, and relying on it as a decision rule is where the diagnostic error begins. Published data show that stroke can present with gradual onset in a subset of cases, and hemiplegic migraine can produce motor weakness that onsets rapidly and closely simulates an ischemic attack. There is no validated clinical decision rule that reliably distinguishes stroke from migraine in the emergency department.
And that last point is the one I want the audience to sit with. There is no bedside tool, no scoring system, no pattern of symptoms that reliably tells you this is migraine, not stroke, without imaging. The NIHSS was designed to grade stroke severity, not to differentiate stroke from mimics. FAST and BE-FAST miss approximately 30% of acute strokes, particularly posterior circulation events. These tools were designed to identify stroke, not to rule it out. I also want to address something that's happening clinically. We are seeing more and more young patients present with stroke, with myocardial infarction, conditions we historically associate with older populations. We should never dismiss a presentation based on age alone. Every patient with neurological symptoms requires a thorough examination, and if that patient is experiencing focal deficits, even if you think it may be migraine, I would advocate for activating the code stroke pathway and getting the specialist involved early. Let the neurologist evaluate. The cost of that activation is minimal. The cost of not activating is the case we're discussing tonight. So when a physician sees a young patient with a headache and focal deficits and says, "This looks like migraine," they may be right, but they cannot be confident without imaging. And when the stakes include a closed TPA window and irreversible brain injury, probably right is not sufficient. I would favor activating your system's code stroke pathway for any patient exhibiting focal neurological deficits regardless of your differential.
Now let's trace the sequence of decisions in this case, step by step. The patient is a woman in her early 40s, 2 children, working full-time. On a summer evening, she developed sudden severe headache, slurred speech, and right-sided weakness at a family member's home. Her mother, observing these symptoms, calls 911 and specifically reports that she believes her daughter is having a stroke. The closest hospital with stroke capability is some distance away. A helicopter is unavailable due to weather. Ground transport brings the patient to a designated primary stroke center approximately 2 hours and 20 minutes after symptom onset. At this point, roughly 2.5 hours remain in the 4.5-hour TPA window.
And this is an important detail. The patient arrives within the treatment window at a facility certified and equipped to deliver that treatment. This is the scenario the stroke certification system was designed for.
The emergency physician evaluates the patient and diagnoses complex migraine headache. The treatment given is a standard migraine regimen, an anti-nausea medication, an antihistamine, and a steroid. A non-contrast CT scan is obtained. It shows no hemorrhage. The physician interprets this as reassuring. But non-contrast CT has a sensitivity of only 7% for ischemic stroke within the first 3 hours. A negative CT in this window is expected with an ischemic stroke. It does not exclude the diagnosis.
This is the first critical decision point. The CT was obtained, which is appropriate, but its result was misinterpreted. A negative non-contrast CT in a patient with focal neurological deficits does not mean there is no stroke. It means there is no hemorrhage. It really only excludes a brain bleed. Those are different clinical questions with profoundly different implications.
During the patient's time in the emergency department, something else happens. The paresthesia, the sensory symptoms, migrates from the right side to the left side. Despite this, the physician documents normal strength and sensation.
That pattern of sensory symptom migration is worth pausing on because it is clinically significant, and it's the kind of detail we may not catch if we aren't paying close attention. Also, and this is something I've thought about from both sides, patients have a very difficult time explaining and describing their symptoms. We have to make sure we ask follow-up and clarifying questions to try to discern what is significant in their description. Now, I was a patient once, and I found it challenging to accurately describe what I was experiencing. Some people don't have the vocabulary to attach the appropriate descriptors. That's our job, to ask the right questions and listen carefully enough to fill in those gaps.
According to the published case report, the patient's mother specifically asks about TPA. She refers to it as that shot. The request is not pursued. A neurology consult is not placed until approximately 1:30 in the morning, more than 5 hours after symptom onset and well outside the thrombolytic window. An MRI at that point confirms ischemic stroke. The patient is transferred for emergency surgery but does not survive. The cognitive autopsy identifies a single moment in the decision chain where a different choice changes the trajectory. In this case, that moment is identifiable. Paul, walk us through the pivot.
The pivot point is the moment after the CT returns negative and the physician must decide what to do next. At that moment, the physician has a patient with acute onset focal neurological deficits, slurred speech, unilateral weakness, and the headache that was the anchor of their diagnosis. At a hospital with stroke certification, teleneurology, and TPA on formulary, the CT has ruled out hemorrhage. The clock is still running. The standard of care established by AHA/ASA guidelines, Joint Commission Stroke Certification benchmarks, and the hospital's own protocols calls for a stroke alert, for a documented NIHSS score, for neurology consultation, for evaluation of thrombolytic candidacy. The Joint Commission benchmarks target door to CT at 20 minutes or less, neurology contact at 15 minutes or less, and door to needle at 60 minutes or less. None of that happened. Instead, the physician accepted the migraine diagnosis as confirmed and treated the patient with a migraine cocktail. And here's the practical teaching point I want the audience to take away from this. Just activate the stroke alert pathway. Let neurology evaluate. Not activating the stroke pathway shifts all the liability to you as the physician. Activating the stroke alert distributes that responsibility more broadly to the system and pathway itself and can protect you. There is no harm in activating the system. If the neurologist evaluates and believes it is a migraine, you now have additional evidence to support you and your decision-making if the patient later suffers a bad outcome. It doesn't completely absolve you of liability, as we discuss in other episodes, but it gives you a stronger defense and an opportunity to limit your exposure. The pivot point is not, should the physician have considered stroke? Any physician seeing these symptoms would have stroke on their differential, at least in hindsight. The pivot is, what allowed the physician to remove stroke from the differential without imaging confirmation, without neurology input, and without a documented NIHSS?
And this is where the cognitive mechanism becomes visible. The physician anchored on a diagnosis. Once complex migraine became the working hypothesis, the subsequent clinical decisions followed from that anchor, and the information that contradicted it, including the migrating symptoms and the family's explicit concern about stroke, was filtered through the lens of the diagnosis that had already been made.
It's worth pausing on the family's concern because it came up more than once in this case. Families are known to make suggestions or voice concerns. That doesn't mean every suggestion is clinically valid, but we should listen to them and make sure we're on the right path. Families know the patient far better than we do, and they're likely only trying to help. It should be a point where you stop and ask yourself, have I overlooked or moved on from a possible diagnosis that has not been eliminated by testing?
Sarah, explain what's happening cognitively.
Two cognitive biases are operating simultaneously. The first is anchoring, the tendency to rely too heavily on the first piece of diagnostic information encountered. The second is premature closure, ceasing the diagnostic process once a plausible explanation is identified, without adequately considering dangerous alternatives. In this pattern, the anchoring substrate is typically the patient's demographics. A young patient, often female, often with a history of headaches or migraine, presents with neurological symptoms. The physician's prior probability for stroke drops. For every one stroke they see in a young adult, they see dozens of migraines. Their pattern recognition, which is usually an asset in emergency medicine, becomes a liability. The research quantifies this. Kunitomo and colleagues surveyed nearly 400 emergency physicians about diagnostic errors and found cognitive factors implicated in 96% of cases. When the initial ED diagnosis was primary headache and that diagnosis turned out to be wrong, the correct final diagnosis was stroke in 80% of those error cases.
I want to add something from clinical practice. When we talk about anchoring, we're not describing a failure of knowledge. These physicians know stroke happens in young people. They know the TPA window. They know the guidelines. What's happening is a failure of process. The diagnosis of complex migraine feels clinically satisfying. These symptoms fit, the demographics fit, the headache fits. And once that diagnosis feels right, the physician stops looking for evidence that it's wrong. They stop asking the question that would change everything. What if this isn't migraine? There's also an important terminology issue here. Complex migraine is not an official diagnosis recognized by the International Headache Society. The ICHD-3 classification system defines migraine with aura and hemiplegic migraine with specific diagnostic criteria, including the requirement that aura symptoms spread gradually over 5 minutes or more, occur in succession, and resolve fully. Complex migraine is a colloquial label, a wastebasket term that signals diagnostic uncertainty without acknowledging it. When it appears as a discharged diagnosis in the setting of acute focal neurological deficits, it should be viewed as a marker that the differential was not adequately explored.
Paul, put some numbers behind this.
The data are consistent across multiple sources, and they point in one direction. Stroke is the #1 cause of serious misdiagnosis-related harm in American emergency departments. That finding comes from AHRQ's 2022 systematic review, the most rigorous quantification of diagnostic error we have. They estimated that approximately 5.7% of all ED visits involve at least one diagnostic error, translating to roughly 7.5 million patients a year. Among those errors, approximately 370,000 patients annually suffer serious harm, permanent disability, or death. For young patients specifically, the data are more concerning. Misdiagnosis rates for stroke in patients under 45 reach as high as 33%, 1 in 3. Younger age increases the odds of a missed stroke diagnosis by nearly 7-fold. And here is the statistic that matters most for tonight's discussion. Among patients who were misdiagnosed after the initial ED diagnosis of headache, the correct diagnosis was stroke 80% of the time. The implications for thrombolytic therapy compound the problem. IVTPA is FDA approved within 3 hours of symptom onset, with guideline support extending to 4.5 hours. Each 30-minute reduction in onset to needle time increases the probability of a good functional outcome by approximately 1.8%. The number needed to treat within the optimal window is 4.5, meaning for every 4 to 5 patients treated, one achieves a significantly better outcome than they would have without treatment. When the TPA window closes, because the diagnosis was delayed, the patient has lost a quantifiable chance at recovery. Without reperfusion therapy, only 25 to 35% of patients with moderate to severe stroke achieve functional independence at 90 days.
And the malpractice data reflects this.
Hazlett and colleagues analyzed 272 stroke malpractice cases and found that emergency physicians were named defendants in 33% of claims, the most frequently sued specialty. The average plaintiff verdict at trial exceeded $9.7 million, and a separate analysis of the CRICO claims database found that nearly half of all ischemic stroke malpractice claims alleged diagnostic error as the primary failure, with the errors predominantly occurring at the initial patient-provider encounter, history taking, physical examination, and the decision about whether to order diagnostic imaging. There is one more data point worth examining. Bott and colleagues analyzed TPA-specific litigation trends and found that 95% of TPA-related malpractice claims alleged failure to administer the drug. Only 5% alleged harm from its administration. A separate analysis of stroke mimics who received TPA found the rate of symptomatic intracranial hemorrhage was essentially zero. The medico-legal exposure from withholding TPA when stroke is on the differential substantially exceeds the exposure from giving it to a patient who turns out to have a mimic.
Sarah, what does the legal landscape look like when this pattern reaches litigation?
3 legal concepts converge in these cases. The first is breach of the standard of care, AHA/ASA guidelines, Joint Commission certification benchmarks, and a hospital's own stroke protocols establish what a reasonable physician is expected to do when a patient presents with focal neurological deficits. When none of those steps occur, no stroke alert, no NIHSS, no neurology consult, no thrombolytic evaluation, the breach is straightforward to establish. A certified stroke center that fails to activate its own stroke pathway for a patient with focal deficits faces heightened scrutiny. The second concept is causation, and this is where stroke cases become particularly powerful for plaintiffs. The TPA window creates a measurable timeline. If the patient arrived within the window and the diagnosis was delayed past the window, the plaintiff can argue, with statistical support, that the delay deprived the patient of a quantifiable probability of a better outcome. This maps directly to loss of chance doctrine, which approximately 20 states now recognize as independently compensable. In the case we're examining tonight, the causation argument is especially strong. The patient arrived with more than 2 hours remaining in the treatment window. The hospital had every resource needed to diagnose and treat within that window. The delay was not caused by resource scarcity or ambiguous presentation. It was caused by a diagnostic decision that foreclosed the workup entirely.
And there's a third element in this particular case that substantially damaged the defense.
The chart alteration.
Yes. After learning the MRI results, the emergency physician went back into the electronic medical record and added cerebrovascular accident to the differential diagnosis retrospectively, without annotating that this was a change made after the fact. For any physician listening, this is the single most destructive thing you can do to your own defense. The medical record is a contemporaneous document. When you alter it after learning the outcome, you are not correcting the record. You are destroying its credibility. The jury, in this case, learned about the alteration. In at least one post-trial account, the defense's extensive discussion of TPA's risks, arguing the drug was dangerous and wouldn't have helped, reportedly had the opposite of its intended effect. Jurors interpreted it as the physician knowingly withholding a life-saving treatment.
The jury returned a verdict of $3.5 million for the plaintiff. The state's medical malpractice damages cap reduced the award, but the verdict itself, against a physician at a certified stroke center who had the tools, the time, and the resources to diagnose and treat, establishes the pattern clearly. And this case is not unique. A separate case involving a 26-year-old woman with migraine history who was discharged from an emergency department with a diagnosis of acute migraine headache was affirmed through the New York Court of Appeals, establishing at the highest state court level that discharge with a migraine diagnosis, when stroke has not been excluded, constitutes a deviation from the standard of care. Another case involving a 38-year-old woman who presented with the worst headache of her life was treated with a headache cocktail and discharged without any imaging at all, produced a jury verdict exceeding $70 million. The pattern is consistent: young patient, headache-related presentation, premature diagnostic closure, no imaging or CT-only imaging, discharge and return with a completed stroke. Verdicts in this pattern are among the highest in emergency medicine malpractice.
Paul, this case originated in the emergency department. Why should the hospitalist audience care?
Because hospitalists encounter this pattern from multiple directions, and in each scenario, your clinical decisions and your documentation determine outcomes, both for patients and for yourself. The first scenario is the ED to floor admission. A patient is admitted with a diagnosis of migraine observation or atypical headache. As the admitting hospitalist, you inherit that diagnosis. If the patient's symptoms haven't resolved, or if the neurological examination doesn't match the diagnosis, you have an opportunity and an obligation to reassess. Your admission note, your documented neurological examination, and your differential diagnosis create the contemporaneous record that will either support or undermine whatever happened in the emergency department. And I want to acknowledge a reality that complicates this. Many of these admissions happen overnight. The hospitalist accepts the patient by phone or through the EMR, reviews the ED note remotely, and doesn't lay eyes on the patient until morning rounds. That's a gap of 6, 8, sometimes 10 hours where the patient is on your service but hasn't been examined by you. If the ED diagnosis is wrong and you haven't seen the patient, the window may close on your watch. That doesn't necessarily make it your fault, but it puts you in the causation chain if the question later becomes, who had the opportunity to catch this? The practical lesson is, when you accept a neurological admission overnight sight unseen, your first encounter note in the morning needs to include a complete neurological exam and a fresh assessment of whether the working diagnosis still holds. If it doesn't, escalate immediately and document the time you first examined the patient, because that timestamp matters. The second scenario is the return visit. A patient was discharged from the ED with a headache diagnosis and returns with a completed stroke. As the hospitalist managing the acute stroke admission, your documentation of the clinical findings, the functional deficits, and the treatment course becomes the evidence that establishes what was lost. Plaintiff attorneys will contrast your detailed documentation of the patient's devastating deficits with the ED's sparse documentation of a migraine. The third scenario, and this is the one I think about most, is the admission where you have the diagnostic question in front of you. A patient on your service develops new focal neurological symptoms. The differential includes stroke. This is where you activate your code stroke pathway. Your workup, your documentation of clinical reasoning, and your decision about imaging and neurology consultation determine whether the patient receives timely treatment. In each of these scenarios, the standard applies. When focal neurological deficits are present and stroke has not been definitively excluded with appropriate imaging, stroke must remain on the differential and be actively investigated. That standard does not change based on the patient's age, migraine history, or the working diagnosis provided by the previous clinician. And I want to emphasize this next point. We exclude stroke in younger patients more readily than we should. I see it in my own practice environment. A 30-year-old comes in with a headache and some numbness, and the reflexive thought is migraine. Not because the workup supports it, but because the demographics make it feel unlikely to be anything else. That instinct is the exact cognitive pattern we've been discussing for the last 30 minutes. The data tell us stroke incidence in young adults has increased more than a third over 3 decades. 1 in 3 young stroke patients is misdiagnosed. The patients we're most comfortable sending home with a migraine diagnosis are the same patients who face the highest misdiagnosis rates. That should give every clinician a moment of pause, not about whether you've been wrong before, but about whether your threshold for imaging in a young patient with focal deficits is where it needs to be.
Every episode of the Cognitive Autopsy ends with one actionable change. Paul.
The one thing is this: any patient presenting with new focal neurological deficits requires imaging to exclude stroke before you accept an alternative diagnosis, regardless of age, regardless of migraine history, regardless of how convincingly the presentation fits a benign pattern. This is not a complex clinical decision rule. It does not require a scoring system or a checklist. It is a single principle: focal deficits demand imaging. If you are the emergency physician and a young patient presents with unilateral weakness, sensory changes, speech difficulty, or visual field deficits, image first, diagnose second. A non-contrast CT rules out hemorrhage, but it does not rule out ischemic stroke. If the CT is negative and clinical suspicion persists, MRI with diffusions-weighted imaging has significantly higher sensitivity, and while imaging is being obtained, activate the stroke pathway. Document a NIHSS score. Contact neurology. These are parallel processes. They do not require a confirmed diagnosis to initiate. If you are the hospitalist inheriting the case, perform and document your own neurological examination. If the patient was admitted with a headache diagnosis and has focal deficits on your examination that are unexplained by imaging, advocate for further workup. Your chart entry that says focal deficit on exam, not explained by current workup. Stroke remains on differential. Recommend and order MRI, DWI, and neurology consultation may be the intervention that changes the trajectory. And document your reasoning. Not just what you ordered, but why. A chart that reads considered acute ischemic stroke versus migraine with aura, given acute onset of focal deficits in patient with vascular risk factors, obtained emergent CT to exclude hemorrhage, CT negative, proceeding with MRI, DWI, and neurology consult to further evaluate for ischemic etiology, patient advised of urgency of workup. That chart is defensible. It shows that you thought about stroke, investigated it, and communicated with the patient. A chart that reads migraine discharge is not defensible. And in the cases we've examined tonight, it was not defended successfully.
One legal point to add. The documentation Paul just described does more than protect you in litigation. It creates a record that, if the diagnosis does turn out to be migraine, supports that you exercised appropriate clinical judgment and systematically excluded the dangerous alternative. Documentation of the reasoning behind a correct decision is nearly as valuable as the correct decision itself.
And I want to acknowledge the clinical reality. Most young patients with headache and transient neurological symptoms are more likely to have a benign process than an acute stroke. The base rate favors that. But the base rate is also the mechanism of the error. Because emergency physicians see migraines far more often than strokes in young patients, their pattern recognition defaults to migraine. And that default, when it's wrong, produces irreversible harm in a time-sensitive clinical window. The purpose of imaging is not to overrule your clinical judgment, it is to give your clinical judgment an objective foundation. When the MRI excludes stroke, you can anchor your diagnosis on migraine. You can discharge with confidence, and your chart reflects careful medicine. When it reveals an infarct, you've just saved a life, or at the very least, preserved the chance at meaningful recovery. Either way, the imaging changes the conversation from "I thought it was migraine" to "I confirmed it was not a stroke," or "I caught the stroke in time." You can't truly confirm it is a migraine, but you can confirm that the dangerous alternative has been excluded. The first statement is a defense, the second two are the standard of care.
Tonight's cognitive autopsy examined a diagnostic pattern that AHRQ has identified as the leading source of serious misdiagnosis-related harm in emergency departments. A patient with focal neurological deficits at a primary stroke center. A diagnosis of complex migraine, a term that is not a recognized medical diagnosis, and that, in this context, functioned as a signal that the differential was closed prematurely. A TPA window that closed because the cognitive pathway closed first. The anchor case produced a multi-million-dollar verdict and was published in a peer-reviewed case report as a teaching example. It is one of dozens of cases sharing the same 5-element failure pattern. Young patient, headache presentation, age-based anchoring, no imaging or CT-only imaging, and discharge without documented stroke exclusion. The one thing: new focal neurological deficits require imaging to exclude stroke before you accept an alternative diagnosis. Regardless of age, regardless of history.
Stroke is rising in young adults. The incidence has increased more than a third over the past 3 decades. The patients who are most likely to be misdiagnosed are also the ones who respond best to treatment. They have fewer contraindications, lower complication rates, and better functional outcomes when TPA is administered within the window. The system that produces this error is not broken in a way that requires new technology or new guidelines. The guidelines exist, the imaging exists, the treatments exist. What's needed is a practice pattern that treats focal neurological deficits as a vascular emergency until imaging proves otherwise, regardless of the patient's age, regardless of their migraine history, and regardless of how comfortable the alternative diagnosis feels.
The Cognitive Autopsy is a premium companion series from the Charted Defense. If this episode changed how you think about a clinical pattern, share it with a colleague. New episodes examine one diagnostic failure at a time, because the lessons that protect patients are built one decision at a time. I'm Bryan.
I'm Sarah.
And I'm Paul. Take care of your patients and take care of your charts.
This podcast is produced for educational purposes only and does not constitute legal advice or medical advice. Clinical guidance reflects general principles and does not replace individualized clinical judgment. Case details are drawn from published court records, peer-reviewed medical literature, and publicly available regulatory documents. Physicians should consult with qualified legal counsel regarding their specific circumstances and jurisdiction.